Okay, you guys ready to get started?
Yes.
No, these guys don't. You can keep eating the donut for now, and then yeah. So guys, thank you so much for coming. I was just telling the ladies over here that I am just super impressed with the attendance today. So thank you so much for coming.
Yeah.
Sorry if you have to stand for a little bit, but we're gonna get moving soon anyway. So it won't be a big deal. Maybe we can take turns sitting or whatever. Also, speaking of taking turns, we have some cheat sheets that we will hand out that are basically like an outline of today, some reminders of some of the facts and things that we're gonna be going over, which is super cool, but we'll hand those out in a minute after we ask you guys a couple of questions. I'm AJ Cohen,
Joey
owner,
Prisbilla.
and this is Joey, who's my lead PT. And we also have Matt here, who's another physical therapist with us, and he's also awesome. But anyways, so if you don't know anything about us, the quick and dirty version is that 6 PTs, a couple of admin staff, every single one of us has worked in a traditional setting and have been at that like place where it's just like unable to deliver the care that we think our patients deserve because of the system that we're working within. Maybe borderline burnout, lots of just factors that are quite frankly a little bit sad just looking at the industry as a whole. But we just knew that there had to be a better way. And so that's why I started Up and Running, where we're able to provide the quality of care to our patients that gets them better quicker and allows us to thrive, allowing us to get the best results for our patients. So that's a little bit about us. Our reputation really started, like my biggest passion when I started the business was running. Of course, we can use the term up and running for really any individual, but running in the name, running is very important to me, a huge part of my life, as well as I know Joey as well.
Oh, yeah.
So this is something we're super, super passionate about and absolutely our wheelhouse. And then we have actually fairly quickly, grown to be the, according to Google, the highest rated PT clinic in Northern Colorado. And so we're super proud of that. And it's because of just choosing to like go outside the box a little bit, so to speak, and do what we do. And so part of that is we don't market to physicians, we don't bring them lunches, we don't do that sort of marketing because we don't want to work with patients who are just going to PT because their doctor told them to. We want to work with folks who, like this is just as important to them, staying active and being healthy long-term as it is to us, right? And so we do what we call direct to patient marketing, right? And so that's where we actually get out there, we just try to deliver value, and by delivering that value, we hope that, when folks need some help, that they think of us. So that's a little bit about us. And then, Joey, do you want to just give a little bit of like a super brief intro to like what exactly we're talking about today?
Yeah, so we're going to go over essentially the aging runner and some considerations that we should all have in our minds. We said aging is 35 to 60 to 70 plus, basically, because that's when things start to change. And so with, yeah, and it's so funny. I was talking to a patient yesterday, and of course I'll be honest, I'm 36, you're 35, right?
The masters runners.
Yeah. So I kind of figured we were going to immediately get some flack for like you're doing 35 and up, but you're also 35, 36. So a patient yesterday totally just laughed in my face, like, oh, wait, you're doing a master's thing? But you know what? We work with these patients. We work with people that are 35 to 60, 70, trying to run, hike, do things that are great. And so we feel very comfortable talking about this. And we want to go over the things that change naturally and the things that we can affect, meaning, do we have a say in this process of aging? And absolutely. Are there things that are just going to occur? Yes, but we do have a say in it. We can slow it down and we can perform. So that's kind of what we're going to be going through. Yeah.
Real quick, is there anybody who didn't formally sign up that you didn't get on this list just for the giveaway later?
I've got everyone, I believe.
Okay.
We have some latecomers.
But that's okay. We can also get it later.
I know that
too.
guy though, so I don't have to.
Just make sure before we do the $50 Runner's Roost gift card giveaway that you put your name on the list. If anybody brought a friend, we're going to give you a couple more, maybe like 2 more names in the hat. Just because we did talk about that over text. Anyway, so there are a couple of things that happen as we age, but before we start just looking at the research and what exactly is happening, fun fact first, number 1 is, who knows what age masters running starts? 40. Does anybody know what age masters running starts in Europe? 35.
35.
Yeah. Anyway, but yeah, we do start. Can anybody guess the age that we start to see some of these changes in the body? Well, just any changes, age-related changes that, let's say, will decrease your running performance.
40s. It's 28.
30s. I think we had one person over here saying 30s. So we do see them probably. Do you guys feel like that's earlier or later than you thought?
Minor at that age.
It's minor, absolutely. And the
Correct.
really cool thing that it's going to be the repeated mantra of today is most of these changes we can massively attenuate or slow down the decline, almost make it completely negligible if we do the right things. And so anyway, and then you can also start that attenuation process at any time, obviously, if we do the right thing. But in case you're behind that ball a little bit, but yeah. So what are some things that you guys have felt maybe already occurring as you've been aging as a runner?
Sore feet.
Low back, so maybe pain in some areas. What was that?
Sore feet.
Sore feet. Once again, pain in some areas. Stiffness. Can you describe what you mean by stiffness?
Hard to get out of bed.
Yeah.
Hurts to get out of bed.
So before running.
It takes a while to get loose when you start moving.
Yeah.
Okay, what else?
More sensitive to temperature, hot.
Absolutely.
I call it joint replacement.
Joint replacements.
I feel like my thing is not knowing what the pain is telling me.
Yes,
You know, so
absolutely.
like I'm used to like, oh, it's gonna hurt sometimes when running. I did a trail run the other night and I wanted to sit down and cry halfway through it, but I ended up being okay. But I'm still sore from Tuesday. But another time I was like, oh yeah, okay, my Achilles hurts some, whatever. But then I ended up seriously injuring it. So that's the thing that's hard to tell. It's like what is happening? Is this a, like I'm just sore, or is this a, oh, I'm really hurting myself?
Yeah. Did you feel like you had a better grasp on that when you were 15 years ago?
Yes.
Yeah? Okay.
It was very obvious what was workout sore,
Uh-huh.
like just,
Yeah.
strain sore, and what was like potentially an injury.
Yeah, absolutely. Yeah.
For me, I like to find remedies on my own, but I'm like, is this a bone, a tendon, a ligament, a muscle, a joint? I'm like, I don't know what the issue is because I don't know anatomy. So
Yeah.
I'm like, is it inflammation or is it more of like do I have a chip in my bone? Or,
Yeah.
you know what I mean?
yeah.
So not knowing exactly what the issue is.
Absolutely. Just chiming in there, fun fact-wise, we tend to see with younger runners, like I would say, teens and early 20s and stuff like that, we tend to see a lot more bone stress injuries. You definitely can see the more musculotendinous injuries, but we see it shift massively to where, runners 30, 35 and up, they tend to start getting primarily tendon-related disorders. Those are the big injuries. Of course, as we age, we're going to start having more joint pain and stuff like that too. But just statistically, so fun fact, if somebody comes in and just their age alone and where the pain is, statistically we can say like, oh, well, we're looking more at the tendon. Let's rule out tendon first. But
Which is a bit of a paradox in a way, right? Because we technically lose bone density over time. Most of us, on average, will lose some bone density. So you'd think bony issues would be a problem. But then there's other factors like training volume intensity that are probably playing into not getting those issues and getting tendon issues instead. Yeah.
what other bodily changes? I mean, like just performance-related potentially?
Lower recovery.
Yeah, slower recovery. You said that word, the S word. Slowing down. I thought that was gonna be like the first one, right? Everybody talks about like their, we always hear people, complaining about their pace dropping or whatever. But yeah, and then like strength, as well. So does anybody know what a VO2 max is? Yeah, it's basically like your fitness. So how fast you are as a runner is mainly a function of two things. So your VO2 max, which is how well and efficiently your body can take oxygen and deliver it to your working muscles. And then we have running economy. These terms I'm defining because we will talk about them a little bit moving forward throughout the workshop. But running economy is going to be more of like, efficiency is not the same term. I don't like to use those synonymously, but it's basically how much energy you need to expend to run at a certain pace. And so as we age, let's say you're running a 10-minute mile, the amount of energy it takes you to run a 10-minute mile at 30 years old versus 50 years old, it's going to be obviously more energy expenditure to maintain that same pace, right? So we tend to see reductions in VO2 max as we age, just plainly from age-related changes. And we also see, based on mainly from tendon-related changes, we tend to see a reduction in tendon stiffness, which this type of stiffness is a good stiffness. So think of a spring. Okay, think of a springboard in a gym. I was a gymnast way back in the day, so I'll use the gymnastics analogy. And I'm going to do a vault. Now, do you think I would get more explosive kind of like height in my jump off the springboard if there were tight springs, strong, tight springs, or like kind of like stretched out springs, like less stiff springs? With the stiffer springs, as long as I can put that, force into it. So there's more energy storage and release, which makes up a lot of that running economy. A lot of that running economy comes from your tendons, especially your Achilles and your patellar tendon, being able to absorb, right? You're kind of falling onto one leg when you run a little bit, and then being able to absorb that and recoil that energy so you don't lose it. It doesn't all go into the ground or get eaten up in the body. You can actually use some of that to propel yourself to the next stride. And we lose a lot of that springiness. And that's why from like a gait perspective, which we'll sprinkle in here, a lot of you may notice gait changes or like running form changes as you age too. And these can be from either decreased range of motion in certain joints potentially, but especially the decreased like springiness or stiffness in our tendons. We tend to adopt as we age a more grounded running style. So we can think of more like bounding and short ground contact time versus more like a grounded running style, right? Has anybody seen that happen to themselves? More grounded running? Yeah. You can start handing these out probably while I finish this up. Okay, cool.
So real quick, which one do we think we have more of an effect on? As far as like VO2 max versus running economy, which one can we slow down the degradation of a little bit more? Which one is more of our the decline in VO2 max? Yeah, it's a little less in our control compared to running economy. We can actually keep up running economy a little bit better. Would you agree?
You can slow down significantly both, but yes, yeah. So there's actually a case study. I forget all the details. It's been a couple years since I've like reviewed this specifically, but there's a father-son runner duo that their thing ever since he was a boy, he would run a 5K with his dad every single weekend. And then they did a case study on them because you could look at they did it like 30 years apart or something like that. So the dad was probably like 35 when they started this, and he was like 65 when it ended. And they looked at his performance as he aged because his son forced him into this like relationship where he was like having a 5K, racing it every single weekend. He barely lost any fitness over those 30 years because every weekend he was doing intensity and he was training for these races as well. So it was just crazy. They've been on podcasts. I'll try and find, maybe I can like blast it out to you guys if you're interested in seeing that. But very cool story. But yeah, you can definitely attenuate both the running economy through usually like strength training, maintaining intensity throughout your running, and the volume as well. But then like the VO2 max changes, yeah, of course, like that's a function of as you can see here, your stroke volume, a lot of like your maximal heart rate, stuff like that. That's going to decline, and you cannot prevent that decline, aspects of that decline over time. But I like to think about it as the FDI principle. I bring up a lot when helping runners ramp up their training. Frequency, duration, intensity. If you can maintain your frequency, so how many runs you're doing per week roughly, duration, so how many hours of running you're doing per week, and the intensity of running, so sprinkling in some running fast, preferably weekly, but if you're not there yet, building up to it or whatever you can do. Those three aspects, if you can maintain over time, you'll massively attenuate your fitness loss over time. So the mantra of this workshop is the consequence of taking time off for somebody who's young is not very much comparatively to somebody who's older. If you're younger, you bounce right back. You can, like, if you took 6 weeks off because you had some Achilles tendinopathy or something like that, they'll probably bounce back. They'll probably be able to regain that fitness. They're not at their like peak yet. It's much less consequential. Once we're 35, 40, 50, whatever, and we take time off or we reduce our training unnecessarily, because most of the time you don't need to do those things significantly, you start digging yourself into a hole that's extremely difficult to get yourselves out of. So the consequences of taking unnecessary time off are massive. And so my goal for you guys today is to just ingrain that into your brains. And what I want you to walk away from today is that you are on this kind of like path where it's going to decline over time. Now, if you take this, if you take a bad strategy moving forward with managing pain, stiffness, and injury, you can accelerate this decline, or you can attenuate this decline, right? And so that's what we're trying to leave you guys with is the knowledge and the strategy to be able to attenuate that decline. But the biggest way you can do it is if you get injured or you have some pain, stiffness, or injury, you get it figured out right away, and you avoid, like the plague, taking unnecessary time off. Okay, does that make sense?
Yep.
Cool. That was pretty much it. We can move on to the next category.
Section?
Yeah, just for
Perfect.
timing's sake.
Cool. Okay. Yeah. So next we're going to go over, as you see on the sheet, like 3 really big considerations that we can all take into account to make some improvements in our running, and just how to look at these changes occurring over time and how we can affect them. When I have a patient, whether they're 20 or 65 that they want to run in the clinic, there are so many things that we can look at, and we can look at them individually, but this list is not exhaustive. It's the 3 kind of top things that we want to consider that we all will have to work on probably over time to optimize our running, or if you're not a runner here, which would be kind of interesting, hiking or whatever, you know what I mean? So the number 1 on that list you see is calf strength. So who knows the intensity, the amount of load that a calf complex has to deal with when we're running? So how many times? Us 20 to 25. So I want everyone to go up onto their tiptoes slowly and come back down. We're going for full range of motion. Someone, make sure we're counting our own. If you really want to test this, go all the way to 20 or 25.
Balance.
Yeah, are you balancing?
Okay, a couple of, just keep going, try to count while you're listening, but yeah, and if you can hang on to something for balance, definitely helps. So nice and slow, try and get up. You don't have to force getting as high as you can, but the one thing I want to be strict about is don't let that heel stay on the ground too long. The second your heel touches the ground, you're going right back up. So there's no rest kind of in between these repetitions.
Try not to bend
nice
the knee
and
you're
slow.
standing on.
Typically 2 seconds, up, 2 seconds down.
Is anyone's calf burning yet? Yeah.
So the point where you'd cut off and say that's your max is failure to reach peak of like basically how high you're getting each time. If you're dropping in amplitude, that's when we would cut the number off. Another indicator of failure would be if we used a metronome, which I sometimes like to use in the clinic, if you're unable to stay in sync with the metronome anymore. But
yeah.
Okay.
So my uninterned leg is weaker than my previously injured leg. Does that make sense?
Yeah, sometimes we see that if,
Worked on this?
yes, exactly. If you've done
I
some
see that a
strengthening,
lot
yes.
actually. So you never want to assume too much. Yeah. Cool. So most of you are probably getting up to that 20 to 25. Hopefully you've been counting, but the fact that you're still going, some of you, great job. Any observations?
My left leg is stronger than my right one.
Okay. So maybe some quote unquote imbalance or some differences in strength.
My shoes affecting it. You normally do these with bare feet, and my shoe makes it.
You should be able, if anything, a shoe could theoretically help a little bit. It kind of creates that little exoskeleton of to propel you upwards. So yeah,
It feels really different.
yeah.
Cool. While you guys are just finishing that piece up, I'm super passionate about the calf, mainly because like the glutes get all the attention, but meanwhile the calf is working 4 times as hard when we're running. So the reality is that the calf is the hardest working running muscle we have, and simultaneously it declines the fastest with age. So not a good combination. We tend to see a lot of calf strains, Achilles tendinopathy, and also related kind of like foot issues and or plantar fasciitis, stuff like that. In folks, runners ages 35 to 60 or whatever. So just definitely, if you have any sort of opportunities here, this is something where you definitely want to be working on this. Slow, heavy resistance training, calf raises, off a step, adding weight over time. I mean, 3 sets of 10 is totally fine. Just increase the weight as you get stronger. But like, do not ever stop doing calf raises. I'm sorry, but like any runner over the age of 35, or if you're younger and you already have had calf or Achilles issues, you are sentenced to life with calf raises 2 to 3 times a week. I'm not kidding. And it's boring, but you need to get it done. So think that's all I wanted to say.
Yeah, the amount of calf strains that if I'm looking at someone's like intake form and it says calf strain, I usually guess that individual is probably 45 to 50 years old. Like, and it's usually correct. And so it's something that we can affect and negate potentially as far as injury. And the same stuff with like Achilles issues. Yeah.
Yeah, and so just 25, if you're under 50, 25 solid reps. Honestly, if I was one-on-one with you in the clinic, almost every single one of you, I would tell you to slow down and take less of a rest at the bottom of that heel raise. So it would probably be harder than what you were doing here. And so just keep that in mind, 25, and then it's decreases by 5 repetitions, that benchmark, for every 10 years. So 50 to 60, that benchmark's 20, 60 plus, it's 15, okay?
What is your opinion on using, my last physical therapist had me using a dumbbell?
Yeah,
Oh.
absolutely.
Kind of doing them with that,
Yeah.
and then doing like.
Yeah, this is an assessment of like how strong you are, right? But as far as treatment or getting
This is the
stronger,
test, yeah.
absolutely adding load is going to be a good
Yeah, this
idea.
is just the test. I wouldn't want you doing the exercise this way, like reps, like 25 reps per set.
That's a good
I would
question.
want you doing, like 6 to 12 reps, but I'd be more concerned with like what level of fatigue or intensity you feel at the end of every set. That's what I would be. So if like, Mary only needs body weight, but you need a 10-pound dumbbell, but you're both achieving the same amount of fatigue by the end of the set, you're both in a good place. Does that make sense?
And why is it single so much better than both at the same time?
Your calves are too strong. I mean, unless you can go to the gym and you have one of those like big old machines and you're cool with all that weight through your spine and stuff. You know what I'm talking about? Those calf raise machines where you get in, it's on your shoulders and that's fine, right? But otherwise, it's just too hard to load yourself at home with what we have at home. So dumbbell's great. I love to see runners doing this religiously and getting really strong to where you graduate from a dumbbell to like a backpack with stuff in it, right? So that you can because you get limited by how much you can hold in one hand during your heel raises, right? If you do it off a step, I really like that too, because you get more into a stretch of the calf. And so that definitely helps, especially if we run hills. And then also the calf, when it is a little bit in this dorsiflexion, is when it has peak force. So we do want to strengthen beyond that neutral position. So off a step makes it harder too. So anyway, you may, great,
Yeah.
perfect.
Yes,
The
similar to
only
a step.
issue
Yep,
with the
that's a really
slant
good
board,
idea.
especially if you wear like zero drop shoes, I tend to see ultra toe, but most aging runners have stiff first toe anyway. So your big toe, if your big toe is stiff or you have issues with like bunions, hallux valgus, stuff like that, you probably want to avoid the slant board because it puts a lot of strain through that big toe. But if it's comfortable and you like it, totally fine. Okay? The step, doing off a step will not stretch and crank on that big toe as much. Anyway, cool? Moving on.
Yeah, just last note on there, from an injury perspective, if you have like a calf issue or even Achilles issue, there are different like flavors of these problems. And so it takes kind of a fine-tuned approach to go, this is what you need right now. And that's more the PT side of it, right? But we're kind of talking about right now just the performance and the calf strength. Cool. All right, next group of muscles we're going to talk about are essentially the lateral hip and the core and the trunk stabilizers. So the activity we're all going to do together, or if I back up a little bit, when we're running, essentially it's a single leg hop to hop almost, right? And so you can imagine that there's some stability, some coordination involved in the trunk and in the hip to be able to not look like this when we run. I'm exaggerating, but we see these things all the time, right? Or to be not holding upright positions and postures and things like that. So the assessment that we're going to go through is just to stand on one leg. We do this a little bit differently in the clinic, but because we don't have equipment, we're just going to simplify it. You're going to stand on one leg. You can either just hold this leg up like this, or you can reach it out like that. And we're going to do a single leg dip. And so I want you to try to do 10 of these. And I'm just going to look around the room. I usually try not to tell patients what to do other than just bend their knee and go up and down 10 times. And
10 times each side. 10 times in a row.
Mm-hmm.
10 times in a row.
Yeah.
In the clinic, we use a step, a small step, and we'll do it off the step. But just for the sake of convenience here. Honestly, I prefer to have my patients keep their hands attached to their hips so we don't see these balance strategies. I want to see how your hip is going to stabilize instead, right? Because this is helping your hip. I want to see what your hip does without that assistance. So hands on hips or across your chest. Across your chest is a little harder just because your center mass is higher then. So across. Yes.
What'd you
No,
notice?
why is it hard?
Well, first of all, I haven't been able to run in 15 years.
Okay.
So I'm more
Challenge
of a
accepted.
specialist.
By the way.
Yeah. That was
I've heard that before.
That was my natural inclination as well. Yeah.
But I have a hip replacement, and my sarcopenia has been incredible over the last 6 years.
Yeah.
I've lost probably 15%.
Gotcha.
So I am unstable.
Yeah.
And
Okay.
I'm not going to dislocate my hip again.
That's
Again.
a great idea. Yeah. So you wouldn't start here.
Well, you could do a mini, very, very mini kind of one. Or if you want, you can kind of just do this like little hip drop maneuver, but whatever you're comfortable with. And yeah, she mentioned this big word, sarcopenia. It is written on your sheet there. That is the age-related decline of muscle over time. So we have an age-related decline of bone and an age-related decline of muscle. I forgot to mention this earlier, but I love talking about this because you can't go wrong with getting strong is one of my mantras, right? It's harder for you guys to gain muscle now than it was maybe 10 years ago, but it's never too late. And it's always only ever going to be harder to gain muscle. And the amount of muscle that you have, that you develop when you're younger and able to, is what you're left with for the rest of your life. And so we want to always encourage muscle growth in runners. I don't care what anyone else says, but because that's a whole different controversial topic, but definitely I'm an advocate for that. Same with bones. Anyway, I can talk forever about this stuff. Keep
Yeah,
going.
so just some observations. Some of us had some difficulty with stability, so we had to hold on to something. That's an observation of obviously needing to work on a little bit of stability, some coordination there, some balance. Some of us chose to bend at the hip a little bit more versus bending at the knee. And these are all things just to observe and to go, okay, maybe there's a weakness here. Maybe there's an opportunity to address some hip stability. We're not going to kind of obviously go through and say, you do this kind of thing. But a lot of you did great. So good job. Any other additions with that one before we move on?
No, we're in the clinic. We're assessing how you're loading the ankle, how this lumbopelvic area is stabilizing, how well you're loading the quad. But then, yeah, this lateral hip is really the hard worker here. Third hardest working muscle when we're running, gluteus medius. So, great test for that. Okay.
Yeah, I do tend to have like the running list of important muscles that a runner needs to develop and maintain, and that is on the list of kind of the 4 to 5 important muscles. We already went over calf, obviously. The lateral hip is third, the quadricep is second, so these are really important muscles to be working on, and then hamstring is in there as well. But notice we didn't say glute max. That one is less important for an everyday runner to be hyper-focusing on. Okay. The last thing on the sheet that you'll notice is some plyometrics, which is basically the ability to store and return energy, typically mostly from our tendons, but obviously the muscle is involved with that too. This is something that definitely, who hasn't jumped in like a couple of years? You know what I mean? So we lose that ability if you haven't done it. So we're going to, and again, running is, if we're running at steady state, I always found this interesting. If we're running at just like a normal, easy pace, our muscles are very close to isometric, meaning they're not changing length rapidly. The tendon is actually responding and springing us forward in space. And so to have that ability to utilize that tendon, that's where that running economy and efficiency can come from. So we're going to go through a little test, 30 seconds. Again, if you have any... Yep. Yeah.
Just quick disclaimer, if you're dealing with calf strains, Achilles tendinopathy, foot issue, active injuries, that we're not looking to flare anything up today. And so you can opt out or just be sensible. You do these at your own risk, but it's just a couple of things like this. But anyway.
So 30 seconds, and you can definitely decrease the intensity with these things if needed. So an example, we're going to do this for 30 seconds. If I wanted to see someone really test them, I might have them do this for 30 seconds. So it depends on what we're comfortable with today. But just start at the level you're comfortable with. I'll time everyone. And we're just going to be springy. Spend as little time on the ground as possible. When you feel like you need to stop, stop. Meaning if something's hurting or if you're fatigued, that is okay. That's the test.
Yeah.
We're almost there. Okay, let's call that 30. Yeah. Okay, good. So some different ways of going about that for sure. I look over in the room and I see, and again, there wasn't a lot of direction of how to do it, so no fault. I honestly like to see how people move in the clinic versus saying, move exactly like this. See if you can do this. I just want to see how you naturally move. And so, some people were making this almost like a squat jump and bending their knees, which is okay if that's the goal, right? But this one really is like looking at the Achilles and the calf complex. The observation that I also made was that everyone was on a different rhythm, right? So the timing was different between people, which means that everyone's on a different level of springiness, let's say. Any observations from doing that? Everyone okay? Good, cool. All right, so we'll take it up a notch, and we're just going to spring from one leg to the next. So think jogging in place, but spend minimal time on the ground.
See you guys.
Yeah, and let's go for a run now. Well, it's good to see that everyone feels comfortable doing this today. That means we're all ready to do some running, is essentially what I'm looking at. Nice. Okay, let's stop there. That was good. Anyone have any significant issues with that? Okay. And then we usually in the clinic will take it up to a single leg jump. This is the one that you definitely don't want to force if you don't feel ready for it, if something's bothering you, but essentially 30 seconds spending minimal time.
15
seconds. 30 minutes, no, 15 seconds on one leg.
Do a couple at least, and that just to get a feel for it. 15 is what we're gonna time you guys for, but you can pull the plug whenever.
Sound good? Okay. Okay, good. All right.
Tough one, huh?
Naturally, we have to do our other side, right? Yeah. We're all going to walk out of here crooked. All right, get after it. So this is where some people are going to go, oh, I feel different on this side. I lost track of time.
I have it. 3, 2, 1. Okay.
What's that? Different pains. Okay. Good. Those are definitely things to observe. Yeah.
There's probably the most opportunity in this group with that one right there. I mean, that's really, really going to highlight where you're at, and even younger runners that we work with need improvements in this area, but it's a good test, eye opener for sure. Okay.
But maybe move on.
Yeah, absolutely. Okay, so a little bit, another interactive section we have. There's so many ways that we work with the runner that's in front of us, but we're treating people for the impairments that they have. We don't treat people by their the level of runner they are or the diagnosis that they have. It's more, more or less, but it's more about what specific impairments that you have that are contributing to your issue. And so we've picked just a couple of things that we tend to work on quite a bit with more of an aging or master's runner. And so we wouldn't necessarily do all of these things with everyone, but just to give you guys a taste of something that we might do if we saw something and you could see some potential changes here today, just some cool, quick stuff that we're able to do that we always follow up with other strategies and techniques as well to more so cement those changes moving forward. But let's just say we had somebody who had fairly stiff ankles that we felt like was a contributing factor, part of the root cause of their issue that they're dealing with. Does anybody here have stiff ankles that they want to share?
Definitely have stiff.
Pretty stiff ankles? Cool. Are you cool coming up and being a demo?
Sure.
Okay. What's your name again?
I'm Bill.
Bill. Thanks, Bill. Thanks for coming up here. So a very, very simple test that maybe some of you guys are familiar with that we can do to quickly assess ankle mobility without those fancy goniometers and stuff like that in the clinic is a knee-to-wall test. And so I usually like to just start, and we can just use this bench here since we're in the middle. I usually just like to start to see if they can keep that heel on the ground. We want them barefoot. So you're a great candidate for that. And then just see if they can start with touching their toe to the wall and then just getting their knee to touch without their heel coming off. And then we'll make it a little bit harder after that because usually that's an easy box to check. So top of your big toe. Yeah, and do it again for me.
Sorry.
Okay, cool. And now I want you to back up, let's just say 4 fingers of mine. So now you're going to back your foot up so that, so bring your toe right about there. Let's try it again. You don't have that stiff ankles.
I was
Who's
actually
got stiffer ankles.
when I was watching you jump, I was kind of thinking you don't actually have.
I feel like they're really slow.
That's a
Okay,
different,
ready?
Yeah.
Real quick, everybody, arms overhead like this, and try to keep your heels on the ground and squat. We'll find some. Maybe her. Keep going, keep going. I'll find somebody. Marlon, come here for a second.
Here, you use this so people can see. This is the wall.
Okay, yeah. We'll see. I might have been wrong. It was hard. Take your shoe off real quick, one of your shoes. And maybe you guys have good ankles. I don't know. We'll see. We might use Marlon here. Okay, start with just the first. So getting your toe here. Cool. Touch your knee. Cool. Back up. Right to, we'll do there.
Anything what my left?
Nope.
You can let that
Your
leg
weight
do
goes
whatever
through
you
this
need.
leg, and then that one's just kind of balanced. His are good too. Was it Marianne, right? Marianne? What's your name again? Marianne, that's right. I had it right. Cool. Last try here. Take your shoe off, and as long as you're cool being up here, I didn't want to force you up here, but no, not okay with it? No.
No, she's okay.
Okay, cool.
I'm fine.
Okay, perfect. Let's just go straight to this one. Right there. Oh my goodness. Okay, my ankles honestly are not great. Okay, ready? Okay, so I get a little bit of lift there right at the end, right? So if I waited a little bit more. Okay, see who sees my heel lifting? Okay, cool. So what I might do for this is, and I promise I'm not faking it because you're like, oh, this is just like, I could, whatever. But I'm not formulating these results. But I'm going to, and you guys can do this in a little bit of a different way. You guys can still test. You can test with bringing your foot back a little bit farther. I just like to have a consistent indicator of how far we are. And I want you guys to, you can feel that stiffness or you can see the heel rising in a second here. But then we're going to follow it up with a little bit of a manual mobilization. So we can do this if you're not comfortable getting on the floor on a bench like this. Or I like to do it on the floor, but I'm taking my hand, I'm just anchoring down the heel, and then I'm driving a little bit through my knee with my weight there. You don't need to do this that long.
Margie, that looks good. You're doing, yeah, exactly.
And then, and we'll all do this in a second, but I only did I'm trying to be real quick about this. Let's see. We get some pretty quick changes because the nervous system is pretty cool. Okay, I know I'm blocking a little bit.
So what is the
Feel coming up anymore?
What is the main reason for the stiff ankles? Is it the tendon? Is what?
It could be the talocrural joint, or it could be the soft tissues, so the tendon, the calf complex. This technique would be able to make short-term changes in either of those categories, right? Because if you think of the capsule of the joint or the tendon, or even just the whole muscle tendon junction, they're made of collagen. And what we can actually make short-term changes to collagen structures. And so what I kind of want everybody to break and try real quick is seeing this in action. It's a short-term change that we're making, but then we would follow it up in the clinic with doing some loaded mobility through the calf, maybe some soft tissue work, and then some, we could do even just the heel raises off a step, really focusing on getting a stretch, but then we're working through that increased range of motion that we just opened up. So real quick, everybody find an edge, and I want you to, you may have to back up a little bit. Maybe you use a piece of paper or a pen. You just want a consistent indicator of how far you are from the wall, and try and just get your knee to the wall.
So yeah,
maybe there is somebody here with some stiff ankles.
I like to just use the fist test, so the individual,
Yeah, that's smart.
your fist, you should be able to, you should be able to touch the wall with your knee without your heel coming off the ground there. And Yeah, so you actually probably
Let me
would
know
have
if one
been.
of you does.
I think I
have
saw that too. I just
some
wanna
issues
point it out.
with-
No.
Heel coming up, is that?
Here, let's
Which means,
use
yeah, which
your shoe,
with this
maybe.
test you
So
can't
rub
let it
against
come
the
up.
shoe.
Meaning
Right.
that once
then
the heel
try
comes
and
So
up,
if I can
it's
go
over.
this far, that's it.
Yep, exactly.
Yeah, so you're getting a little
you,
lift
you
there,
do have
so
a
I
little
would
bit of stiffness in those ankles.
Try
So what
that
you really want to
mobilization
do
we
is
just did
what I
for
do in
like
the clinic
30
is like
seconds
here's
or
the
so,
wall.
and then try
you want
that
to see
again
how far away from
and
the
see if
wall
you can get farther.
you can get
Okay.
before your heel has to come up because
So here,
eventually your heel's going to have to come up.
Okay.
But you notice that
So
like this
here.
distance is
do this with
So
me.
right here about is where it goes.
yeah. So you two actually would have been
Kinda get in
good.
this
So
position if you're
now the
comfortable
next
with it.
step is to
And then take
grab
your
the
left
back of
hand
your heel.
And yes, perfect.
And you're
then
just
get your
going to-
elbow right
Make it
here.
stay.
Yes.
make it
You
stay
feel
on the
that stretch
ground.
through the-
Yes.
Yes, perfect. So you're gonna kind of like go
This is
there, come
it
back
can be
off,
calf,
go in
Achilles,
a
or
little
ankle
bit,
joint.
come back.
It depends
off,
on the
go
individual.
outside.
What I see in the clinic a lot is that
Come back off.
people have like
Do
an
that.
ankle sprain history.
Strong but
That
comfortable
side
stretch
is the one that actually
on and
gets
off that
stiff.
end
And
range.
so chances
Change
are
up
everyone
the
that
direction,
showed
do a
us
little
their
twisting
ankles
through
today
that
probably didn't pick
ankle
their,
as you do
their
it.
stiff side to show
Try it for
off
about
with.
30 seconds or so, and then
So,
retest your.
I
your
would
ankle.
see through that and go, let's look at both.
The
But
left side is way more flexible.
yeah, and so that's usually when it like this like asymmetry sounds like a
You
bad
have a
word,
lot
but
of-
for
You have
ankles
quite a bit
it
of
can be a
ankle
big
mobility.
difference.
Yes. No, you have a lot. Yeah.
Locking the heel.
Yeah.
So basically, like you're gonna cup your heel and keep it on the ground. Sorry if I'm in your bubble here.
Yes,
doing the
yes,
dorsiflexion.
absolutely.
Yeah, so you're
Babies
basically
are-
just like
Crazy mobile.
yeah. So you're kind of
Did you
doing that
retest?
same motion,
How did it look?
but you're really gluing that heel to the ground. So you're pushing
Oh
that
yeah,
hand
I mean
down
you're
toward
almost
the
to the
ground.
wall now without your heel coming up. Now, obviously, if you went home
Yeah, that's
and
good.
later tonight,
And you can
chip
push.
and test
I mean, as long as
again,
there's
you'll
no pain, you
probably
can
have
really
lost
push
that
into
increase.
it.
But if
Like, you don't
were
have
to follow it
to
up
be
with
gentle with this one.
whatever, just depending on what we think the restrictions are, follow it up with some soft tissue work or some loaded mobility, some heel raises.
Oh, the
off of
phone
step,
test, even better.
Really
Look at
challenging
that.
that.
That's good.
You'd be
Yeah,
able to
pick
get
an
a
object
long-term
that you
change there, right?
can objectively go,
that's,
hey,
that's a cool thing to see short term though.
yeah. So you're doing
She's got quite a bit of
yeah, you're doing pretty good there.
dorsiflexion. Cool.
You want to pick the low hanging fruit when you're addressing these things, right? So if you have good mobility, move on to your calf strength or explosiveness or something different.
Let's skip to the hip one because that one's cool.
Okay.
And we can clear it. We can borrow a bench from somebody if you want to. You were going to do this one, right?
Yeah.
Okay.
yeah.
Cool.
Okay. So the other aspect, if everyone kind of imagines like a runner in stride, we can imagine that the back limb, the back thigh, is going to be behind our torso, right? When we think about like that graceful stride, we need to get our which we all think we have, right? So we need the ability to have hip extension. So this is the hip joint deep in here, and hip extension means that the femur, this long thigh bone, is going behind the thorax or the torso. So I want everyone to stand, be as vertical as they can with their torso, meaning don't arch your back. You might even
demo
tuck
for
your
you guys.
tailbone a little bit under. Don't lean forward. And see if you can straighten your back leg to
Straighten
get your
the back
femur
leg.
behind you without
Tuck the
leaning
tail
forward.
under. Straighten the back leg. Don't arch at the back. Okay. You're trying to basically stretch. Like imagine your hip flexor is really tight. It's basically like you're trying to stretch that hip flexor, right? So foot back, straighten the knee, bring that torso up, but do it from the hip. Like if you have a tail, this is tail up, this is tail down. Bring that tail down. Who feels real tight?
You've got it. You've
front.
you're pretty mobile, so I don't think that these mobility assessments.
see, you can
You're
also
someone
look
that if I was in the
around.
clinic, would be okay. How's your
Feel it.
strength? How's your power? How's your stability? Just based
Straighten
on
that knee a little
experience
bit
there.
more.
So mobility
There you go.
probably,
That
is
increase
not
that.
the thing you're going to end up
Stretch a
addressing
bit.
based on what I've seen today with
That
you
looks-
doing
she's
some
got
of
a
these
lot of
things.
extension.
Obviously, don't let that be painted with a broad brush. But so
Sure
yeah, does
that
anyone
back leg is
feel
straight?
limited with hip extension, like they're not able to get their leg too far behind them? We want to. It's a tricky.
We have a volunteer.
What's that? It's different.
Well, one size titanium. So.
Oh, maybe we shouldn't use him.
I mean, that's okay.
Does anybody not have a hip replacement that has asymmetry?
I don't think he was going to stop there. I think there was another part of that statement. Does anyone die?
Who felt either stiff on one side or has
He's compensating a little bit. So what's your name again?
Marlon.
Marlon. So we might.
Are you cool being a demo?
Yeah.
Okay.
Yeah, so Marlon, if you stand up here, Marlon,
We might borrow this bench here.
just to kind of show
For-
everyone what
for a
we're
minute.
talking about. And this is
I don't know what I was doing.
this is this is common stuff, right? So
The next thing.
you're going to again stand as tall as you can. Don't lean forward at all, and get that leg, that thigh behind you in space without leaning forward. There you go. Good. And there's a balance component to this with Marlon a little bit here. And so what we have to be picky of is, as from a PT perspective, he's creasing a little bit here. You can tell that his thigh, ignore his lower limb, his thigh does not want to travel easily beyond. So that's some restriction in the front of the hip.
Yeah.
And so that's going to limit stride. When you talked about stiffness, actually, was the thing that you brought up. And so to you, that is relevant. This is relevant. So we'll go through, thank you for showing us that.
Are you cool being a demo for making that feel a little better?
Yeah,
you wanna-
you can do what you did
Do you want me to do
yesterday
it?
with
Come on
with
over
me.
if you're cool with this. Yeah, so something we might do for somebody like Marlon, it's your left hip, correct? Yeah. Cool. Lay on your back here if you can. You're going to have your knees bent, so maybe just like that hook lying position. And so bend your knees so your feet are on the bench here.
okay.
Yep, and then you can scoot up just a little bit for me. Actually, come a little closer to me. Cool, perfect. So I want you to hug this knee so that we can protect that low back a little bit. I want you to keep that down, okay? So like don't let that arch. If that feels like it's arching, let me know, okay? So bring this leg, let it drop off the table. Feeling that tightness now? Yes. Stiffness? Okay.
So this is called a Thomas test.
So just hold. Now we're going to add some active elements to it though. So push against my hand with this. Yep, good. Hold, 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 hold. Okay, relax. Let it rest with gravity. So, yep, it went down a little farther. That's good. Cool. Okay, push against again. Do you guys see how much it dropped between the first and the... Hold. Nervous system is a funny thing. Hold. Relax.
There
Okay.
you go.
Cool. Now, let's bring it up. Okay, hold that position there, but stay off the table with this leg. Yep, hold that. Now, let me win slowly. Slowly. Bring it down, bring it down, bring it down. Slowly, 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 slowly. Okay. And then up a little faster. Up, 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 up. And bring it down, bring it down, bring it down, bring it down. Last rep. Okay, and then you can sit up here and shake it off, walk it off. But then go do what you were doing with Joey again and see how that feels.
Yeah, take your time if you need to get
Yeah.
your bearings. Yeah, understood. So left leg behind you, and then can I give you my hands? Left leg behind you, nice and tall.
Yep, and then bring that.
And so the ability to get the hip behind.
Okay.
Yeah.
Yeah.
How does that feel?
Good.
I mean, we could see the angle of the torso to the angle of the hip is much better than it was before. Before it was kind of angle of the torso to angle of the hip, but now he's got several degrees more hip extension. Where, yeah.
Do it yourself though?
Yeah, so
Of course.
well, this is where somebody like me and Joey comes in. Obviously, we could do something like that and then follow it up maybe with some homework where you're able to do either with a band or a weight that you attach to your foot, or a higher level version with a band and you're in standing. We get that pelvic, lumbo-pelvic control on one side while we're working the hip in the other side, right? So there are several exercises that somebody might be able to do.
Thanks,
we
Rob.
could follow that up and add in some hip mobilization, some techniques to basically allow that joint to move a little bit better and encourage more hip extension. But anyway, so there's some really, really cool things that you can do. If you have little impairments, if you have little areas of opportunity, we can make some short-term changes. You can also make lasting changes off those short-term changes with other techniques and stuff. But we've got to figure out what those areas of opportunity are. We did a couple of little tests today, right, to give you guys an idea. What are the biggest most important things we need to focus on? And then what are some things that you can do right away to kind of address them? So there's so many things we do with folks, but just wanted to give you kind of a taste of some of the short-term into long-term changes that we can make with folks. But as we're coming to the last couple of minutes here, key takeaways for today. So we'll just go in order here. Yeah, so runners that are 35 plus, 30, whatever age you are, just older than 35-ish, You just need a different training lens, not less running, but typically more support work, right? But you just have to be a little bit more strategic in what exactly you're doing. We just don't have the luxury anymore of not having a plan, just going out and flying by the seat of our pants. There's going to be massively more consequences if we don't take things a little bit more calculatedly, okay? And I'm just like the perfect example of that too, because I've been in my past as a runner, very kind of uncalculated. And now, obviously things are very, very calculated because it's what I do for a living. But I've seen just those changes in myself too. We don't want to chase symptoms. We want to fix the root cause. I will add diagnoses in there as well. A lot of times we have people, especially as they age, they start to get more imaging, they start to get more diagnoses, and there's this very, very diagnostic center way of thinking, or diagnosis centered way of thinking, where people are just obsessing over like the diagnosis, when in reality, especially as active adults, it really is just one little piece of information out of many. Sometimes diagnoses are not even the actual reason there is pain or issues. We see this quite a bit with, like, the hip is just infamous for, Joey's got a labral tear, I have a labral tear. I think at one point every single PT on our staff had labral tear. Anyway, so you could have a labral tear and no pain at all, like me, or you could have a labral tear and then get a surgery that you later regret, like Joey. So
It's true.
so we want to avoid diagnosis-centered thinking and instead treat the individual for the individual symptoms, individual impairments that they have that relate to the bigger picture, right? That more holistic approach, okay? And then promptly addressing and fully addressing pain, stiffness, or injury to avoid unnecessary time off. And does anybody, just so that we can demonstrate understanding, who wants to explain very briefly why that's important again?
It's hard to dig out of the hole you make yourself.
Yes, we because you're already losing. Yes.
Yeah.
Don't dig yourself into a hole. We're losing fitness. We're losing strength, muscle mass. We're losing tendon stiffness, running economy, VO2 max, did I say that? As we age. We can attenuate it though, but the more time we take off, every time we take unnecessary time off, it accelerates the loss. So we want to avoid unnecessary time off. The best thing that you can do, there are some people in here maybe in their late 30s to 40s. The best thing you can do is make sure that you're I want to run till I'm 70, like Mary. I want to run that long. The best thing I can do is, no matter what gets in my way, I can try and do everything I can to maintain running, even if while I'm injured, or just don't take massive breaks. Okay, if you're a little older than that, and maybe you've already taken some breaks, the best thing that you can do is figure out what you're currently dealing with, what are your current limitations maybe from previous breaks, recoup as much as you can, and then take that mindset of moving forward and committing to never taking unnecessary time off ever again, okay? If you need to, totally get it. We all go through different phases of life, but now you know the consequences of taking time off, okay? And that's...
You want to do a Q&A or anything with the last couple minutes? Yeah,
absolutely. The Q&As can get kind of long, so just before we ask for just literally tear us apart with any questions you have. I love debunking myths and stuff. There is, for folks who join us today, we do have a limited number of these. I was going to make it 5 because there's so many of you, we can make it 10. It's first come, first serve on these $49 evaluations. It's a full hour with, it'll probably be with Joey, to be honest, but just depending on schedule and stuff. If you hit hiccups, it might be with somebody else. But a full hour where we just literally are working with you one-on-one, figuring out what you need, what's going on, and to get some relief, some answers, and a path moving forward if you like what we're doing and you wanted to work with us further. So it's an additional $10 off the $49 if you use that little QR code and you book your discovery call. There's like a self-booking calendar on that. If you book a discovery call, before you leave here today, because it just takes a second, we'll take another $10 off. No pressure. We just love delivering value, and we want to make it as easy as possible. If anybody feels like they want to come in and see what we're all about in person, hands-on, super easy way to do it. With that being said, hit us with your best questions. Marianne.
When you say time off, so right now I'm training at the Troy City 10K last weekend.
How'd it go?
and I'm trying to prepare myself for
Okay.
the half marathon at Equinox.
Yeah.
So I'm running way more than typically.
Yep.
To get ready for that. But once that's done, I don't want to lose what I've now. Will I ever
Yeah.
do another half marathon again? I don't know.
So the
But the
question,
10K, I'm really happy.
yes.
So when you say like time off, like what's a minimum?
Yes,
Is there a
yeah,
minimum?
I know exactly
like,
where you're
once
going.
a week, you
Yep.
are going to
3 times a
maintain
week for
yourself?
30 minutes. 3 times a week for 30 minutes. Yeah, is really a minimum that we see, and that's to maintain the adaptations as best as possible. But obviously, you can do less than that. But that is a fairly commonly accepted minimum for maintaining
That's
adaptations.
3 times a week doesn't always have to be what you want to. Like say I always want to be able to run a 10K, but I don't have to run 6.2 miles 3 times a week. I could do 3 miles. I could do
Yeah.
4.
Yeah.
Once I do 6. And
What you're doing is setting yourself up for success so that when you want to ramp it up a little bit, you have a platform to work off of versus starting from nothing. I have a lot of patients that, it's Colorado, and so they want to ski during the winter, but they're runners or hikers or whatever. And I'm like, try to keep it in the mix, because you had this injury because in the spring you ramped up your running again. And so you want to kind of balance, hey, make sure you're having fun in life, enjoying it, but keep some consistency because it does a lot.
How much does other activities is even a bonus? Like we're biking
Uh-huh.
right now.
Oh,
getting ready
yeah.
for
Definitely a
trip.
bonus.
And so we're biking, and then we went hiking the other day, and
Uh-huh.
I was like, holy crap.
Yeah, it's not specific. Yeah.
Like,
The
I'm
running.
biking, but I felt that hike.
Yeah.
It was, and so it's like all of that mixing in just helps because you're doing different muscles.
It helps. Nothing replaces running. The loads of running are unique to running, and so that's why we're kind of recommending 3 times a week of running if possible, because we're talking about tissues deconditioning, and running keeps those tissues healthy versus, again, hike, bike, that stuff is good for your heart, your lungs, your enjoyment with your partner, but like running specifically keeps those tissues healthy, ready to run more.
Absolutely.
Related question.
Yeah.
Is it better to run every day or alternate?
Depends what your goals are. It depends what your goals are, I would say. Yeah,
Everyone's different.
technically the more running an individual does, the fitter they're going to be, as long as that's sustainable for them. So
What about they always say like you only have so many miles?
that's not
That's not true.
no, that's not a thing. Yeah.
That's actually not one I've heard in a very long time.
I know that makes me think of something similar that was like heartbeat related, and I'm like, no.
Oh yeah, like you only have so many hearts.
Yeah, no.
I know I saw
Yeah.
Marlon's been waiting here.
So, you say less running. Are you talking volume? Are you talking time? Are you talking,
Yeah, so
what's that mean?
what do you mean by not less running?
Well, you have it here.
Oh, yeah. So, Marianne had a great question, right? She's in a training season right now. She's basically saying, like, when she's not training for something right now, but maybe later, what's the minimum I can do to stay healthy and, like, not lose more than I need to lose, right? That was the essence of your question. Third, I in general, when I'm coaching, programming for my run coaching clients, when I'm talking to patients, I always prefer, especially when we live near trails and mountains, to talk about time at effort, right? So, like, time versus miles. Right? And so, but anyway, in terms of not running less time, is what I would say. Yeah, I know you were next.
So speaking of myths and debunking, everyone says, so plantar fasciitis, everyone says, well, I've heard recently, actually not an itis, more of an osis. And also,
Apathy.
everyone says, like, it's the calves, stretch the calves, but I don't know if that's
Well,
true.
No, this is a good question because it could be extrapolated, and we could talk about the patellar tendon, the Achilles tendon, the plantar fascia, which is the bottom surface of the foot. Basically, it's fascia. It's not a tendon, but we kind of treat it as a tendon. So to answer your question, it is fasciopathy, not fasciitis. And that's important because it means that it's not purely inflammatory driven. And that's the case with a lot of these tendon injuries as well. So when people say Achilles tendonitis, there are a small amount of people that actually have true tendonitis, but that's of the outer covering of the tendon. True tendonitis or tendon pain is tendinopathy, which means degeneration, disorganization of the collagen fibers. And so it's not really like a throw pills at it. It's load it and get it conditioned for the activities again.
Yeah, there's itis, which is like inflammation, algia, so tendinalgia, which is just pain, right? There's the tendinopathy is more of like a syndrome type of thing. Then there's, would you say osis? Tendinosis, usually that assumes there's a breakdown component. So yeah, we usually just say opathy because it's more of an umbrella, tendinopathy. But yeah, the stretching is fun because stretching there's not a ton of really effective interventions in the research for plantar fasciopathy. It actually has like a very strong natural course it sometimes just needs to go through. That's why people struggle to throw everything at it and not see a ton of progress. Stretching, there are stretching protocols that are somewhat effective, but very long-term. There's a study by Ratliff et al., and he basically developed this exercise, which is essentially a heel raise off a step with the big toe raised because that's where the plantar fascia attaches. So a stretched plantar fascia heel raise, a specific protocol which gets people's symptoms better quicker than any other intervention out there, but yet literally, I don't know if we've ever had a plantar fasciitis patient come in our door and they've already been doing this exercise. So it's like a really great opportunity. It's like, I don't know why nobody does this, but it makes us look good because it's like the only thing out there that's really effective for plantar fasciitis. But stretching can work. In this study, they found that the outcomes long-term were the same as this other exercise, but this other exercise got people better quicker. So, fun fact. Yeah. Other questions or myths or anything?
Just questions about like warming up and cooling down. What are some important components to do for those two pieces of the running routine?
Yeah, so my runners, for warm up, I think of it quite literally of getting tissues warmer versus like stretching. So there's no research showing that static stretching prevents injury or really any specific stretching before activity prevents injury. If it feels good, some of us just like stretching. It feels good, that's okay. But if you're kind of painting with the broad brush and saying everyone needs to stretch before, I would tend to disagree with that statement. So literally warming up the tissues and priming them neurologically. What that means is if you're going to do like a quicker tempo run or something, you'll definitely benefit from getting those muscles recruited quicker. Think butt kicks, high knees, dynamic warm-ups. Those are really valuable and can honestly make someone feel really great. And I do notice a lot of my runners have gotten into running later in life and like they haven't done that ever or not since gym class. And those are cool, like dynamic warm-ups to add in. And they can be really helpful and make your running feel easier. Cool down. Do you have thoughts about cool down? I just like
5-minute walk at the end of your run
gradually
can help.
Yeah.
That doesn't have to be fancy. My warm-ups and cool downs are typically not super sexy. It's just walking, brisk walking, because it's the closest thing we have to running. But it depends on your situation and what you're dealing with, and there may be some other things we throw in there. But
that question kind of reminds me of the fact that like there are so many things that a runner could theoretically think about as do I need to focus on this, that? There's definitely a hierarchy, and that's minimal. Meaning, I tell my runners a lot, like if you feel okay, just starting your 6-mile easy run, the first mile slower, that's enough of warm up for me, and that's what I do, honestly. But someone else might need something different, so it's an individual thing to some degree. Yeah.
And stretching after is better, not before.
I'm honestly not a fan of stretching, but if you were going to stretch, after is better. Yes, you are.
Yeah. Yeah, you can technically have performance loss with some stretching. Again, if you're running slowly, it's probably not going to negate. You're not, towing the line for the 400
if stretching
meter.
feels good, go ahead and do it.
Yeah, exactly. It's an individual thing, but everyone shouldn't. Like, I have people that go, "Oh, I haven't foam rolled in months," and I'm like, "Don't feel bad about it." Like, it can be very helpful for some people, but not everyone has to do it religiously. Yeah. The hierarchy.
I know we got to do the giveaway here.
Yeah. Let's.
Real quick,
Be respectful of time.
Yeah, no, I think there's some people waiting about.
While he's doing that, I want to ask a question about like a lot